Welcome to another episode on MedNiche with Dr. B. And today we're looking at the pediatric clinical examination. So we're going to be doing the well-baby child visit. I'll be looking through history taking, whereby the questions you ask the mom. Don't forget, as usual, we start history taking by the moment you're done with identifying data, we go to work history. So I'll be focused on that, on this. So it's the next will be the chief complaints. Okay, so while asking the mom, I want to know the birth history. So I'll ask the mom, what was the maternal age at delivery? That's very important. Now, were there absence or presence of prenatal care? Now, also, were there any form of disease, illness during the pregnancy itself? Now, whatever medications, prescription and not prescription based, or what were the medications you took during pregnancy? Now, I want to know if you took drugs, alcohol, tobacco, any form of this during pregnancy. Also, what was the maternal weight gain? The gestational age of the infant at delivery. I want to know the method of delivery. Was it C-section or it was vaginal delivery? Also, I want to know if there were any form of complications during that delivery. Now, when the child was delivered, I want to know the birth weight, the birth length, even the birth occipital frontal circumference. Now, very important, APGAR scores. So I want to know the APGAR scores at 1 and at 5 minutes. What is APGAR? A for appearance, P for pulse rate, G for grimaces. So I'm looking at, did the child cry at what degrees and the likes? Was there any form of irritability, reflexes you get? Now, A also is for activity. So the muscle tone, flexion, you get the movement. R is for respiration, and that gives you APGAR. We are the scores from 0 to 10. So 7 to 10, that's good. When you're having 4 to 6, that baby needs respiratory support. When you're having anything 0 to 3, resuscitation is necessary. So you see why APGAR scores at 1 and 5 minutes is important to ask the mother, what was it? Now, we also check for the estimation of the gestational age. What was it? Were there problems with feeding? Was there any need for medical treatment like, phototherapy, oxygen transfusions, antibiotics? All these questions are important. Was there the presence of abnormalities noted on examination by the pediatrician? Now, I also want to know if the mother had any form of postpartum health issue. Were there any form of neonatal infections? Any illnesses at all? I want to know all about it. Was there any form of exposure to harmful substances? Accidents or injuries that might have occurred? Hospitalization that occurred? Surgeries? Now, I want to know if any medications were given. Were they complete with dosages? I want to know the frequency. What was the reason for even the medication? Now I want to know if there were any form of allergies to these medications or food allergies. What was the reaction like? The baby's developmental history. I need to know as a doctor. As a medical student, you need to ask all these questions. And also, I also want to ask for immunization history, because immunization has to be up to date. Now, while we are done with the history taking, we go in depth to physical examination. Now, I have my mannequin baby today. Now, so first of all, I have to establish rapport with the patient, the mom. I have to gain consent. Don't forget, guys, in examination room, mention that. And you have to explain the procedure as you perform it, stage by stage. Don't forget, we're going from head to toe. Then, don't forget to wash your hands with soap and water and dry with what? Clean, dry clothes. Make sure you do that. Now, after doing that, you place the baby on a clean, warm surface, or you examine him or her in the mother's arm in a well-lit environment like mine. Okay, so let's go right into it. So let's start the first thing, general observation. Number one, what do we look out for? I'll assess the baby's posture, the movement, checking for tone, color, the activity, breathing pattern. You have to be very observant. I'll examine the skin. I'm looking for any form of bruises, abrasions, hemangiomas, abnormal color of jaundice. This is very important. Pallor. I listen for spontaneous cries or coos. I'm looking at the quality of the cry of the baby. Now I assess the level of alertness and muscle tone. Also, I look for any form of signs of distress, cyanosis, any form of dysmorphism, or syndrome features. Now is the time I check it. Now we go to the growth parameters. We need to measure the weight. So you put the baby on the weight scale. Now the usual range is 2.5 kg to 4.0 kg on the Well-Baby child visit, and 5.5 to 8.8 pounds. So I'm giving you into unit parameters for weight. Now length or height, it must be between 45 to 55. So this is how you go about it. You take your tape measure, you locate the centimeter region, and what do? You make sure you place the baby. Don't forget that when you're carrying the baby, be careful. The neck region, be careful. Look at the way I supported the baby. Now don't say because this is mannequin and you just carry the baby and no. So now you get the support from someone whereby you tick where you see the head starts from, and you tick where you see the foot stand from. And when you carry the baby, then you can easily measure. Because don't forget that when you are holding the baby, to measure the baby will be flipping, moving around. No, we don't want all that. Then what do we go next to? The head circumference. And you measure, guys, you measure the head circumference. Also in centimeter, guys, don't forget. So the usual range is from 32 to 38 centimeter. Now when we have the weight, the length, and the head circumference, what do? We plot on the WHO growth chart or the local equivalent. Okay, now let's go to the head and scalp. Now we're going from head to toe. So we inspect the size and shape. And don't forget, we already measured the head circumference. So we feel for the anterior and posterior frontanels. We're checking for the size, tension, pulsations. These are all important. You check for sutures and any form of overriding, wide open, premature fusion. You look for scalp swelling. Don't forget the likes of the carpus succedaneum, which causes suture. Cephalohematoma, which does not cross suture. All these are important to mention. Now we go to the eyes. Now we inspect for symmetry. We inspect for spacing, eyelid abnormalities. Now we also check for red reflex. That'll be done with the ophthalmoscope. Now anything photoscopy to be a different video entirely. I'll do on that. Let's go on. We check for pupillary reaction. We check for conjunctiva. So you're looking for what? Jaundice, any form of discharge, eye tracking if older infant. You examine the eyes for corneal cloudiness, cataract, any swelling or redness that is on the eyes. You noted how many things I mentioned. These are all important for you to mention and look out for. Now we go to the next, which is ears. So what do we check in the ears? The positioning. You're checking for the shape. You're checking for the size. You're also checking for any form of skin tags. Are they pits? and any form of low set ears. You know, the trisomies. The setting. All these are very important. You check for response to sound, like clapping, bell, do you get? Now, if necessary or when necessary, otoscopy could be done. Okay. Then, when we are done with the ear, we go to the nose. The first thing you check on the nose is the patency of the nose. So we're checking for the coronal atresia. You understand? This is very important. We also check for nasal discharge, or if there are any form of deformities. We check for nasal flaring. When we are done with the nose, we go to the mouth. You can see how I'm going from head to the toe. The mouth and the palate, what are we checking? You inspect the lips, the tongue, the gums, the palate, and the mucosa. You also check for cleft lip. No sign of cleft lip, no sign of cleft palate, no sign of natal teeth, no sign of Epstein's pals, no sign of any form of ankyloglossia, so tongue tie. All these are important. And we can easily do the sucking reflex too. You know, so where you bring something close to the top of the mouth of the baby and the baby starts sucking. So the sucking reflex will be done. Also, we could do at that point in time the rooting reflex, to whereby you put the hand and you just stroke the baby's cheek. At that point in time, you see the baby trying to bring his hand towards there, trying to find the location of what you are doing to do what? To suck. Now, we go to the neck. What do we check for? We check for masses, first of all. So masses like what? Cystic hygroma. Now that is very important. You check if there's any sign of torticollis. That is important. Thyroid enlargement. So you mentioned there's no sign of this. You check the clavicles. Don't forget they are very close to here, to the neck. You check for any form of fractures. And easily you check for any form of passive range of motion. The child, the baby does. Okay. Now we go to the chest. What do? We inspect for symmetry. So I'm looking at my baby's chest. I'm checking for any form of retractions. Also during that period, we check for the respiratory rate and the respiratory efforts. You know, you need to make sure, is the baby having difficulty breathing? Respiratory rate, you know. How we check for respiratory rate? The breath cycle for 1 full minute. Now when we're done with that, we auscultate the heart sounds, where we check for rate, reading, we check for murmurs. So basically, this is a mannequin here. You auscultate and you check for extra sounds. You check for the lungs, the breath sounds. And you need to listen to the babies. If there are any form of adventitious sounds, then you palpate for the femoral pulse, because we need to rule out any form of aortic coarctation. This way, of course, very important, comes under this region. Now, abdomen. What do? We're done with the chest. We inspect the shape. We are checking for any form of distension. We're checking for if there's any form of umbilical hernia. No sign of umbilical hernia. No sign of any abdominal wall defect. We auscultate for bowel sounds too. And we're listening. Let's see, I'm using my diaphragm at the time I was mentioning auscultation. Then we palpate for the liver. So the same way I taught in my videos on abdominal examination is the same thing you're doing now for babies, but you just need to be very delicate. If you notice, even with the mannequin, I'm making sure that I'm watching out for my baby's neck. Now you check for the liver. You see I'm at the right quadrant region, the spleen, the left quadrant. If there any form of kidney masses, any tenderness, guarding, then we percuss for free peritoneal fluid. So you percuss, you get all the quadrants. We go to the 4 quadrant. and you auscultate for intestinal sounds. You also check for the umbilical cord stump. If any is present, you check for redness, any form of discharge. When we are done with that, then we can go to the genitalia and the anus. Now we're coming down. For male, what do? We check the penis. Assess the size of the penis. The urethra, meatus. We're checking either any form of phimosis. The testes, you're checking if it's distended or undescended. The scrotum, you're checking for hydrocele or any form of veneer. In the female baby, you're checking the labial and the clitoris. What are we looking out for? Normal anatomy. So no vaginal discharge or bleeding. You're checking for if there is a patent anus. Now, you're also checking. You note if there's any form of passage of meconium within like the first 24 or 48 hours. When we're done with the anus, then we go to checking the extremities. So what are we looking for on the extremities? Don't forget it. I'm inspecting the limbs, both the upper and lower limbs. I'm checking for symmetry. Don't forget, guys, I told you for everything that is bilateral, we need to check for any form of asymmetry going on. We check for the movement. We check is there any swelling, any form of digit abnormalities. Can you find polydactyl, syndactyl? If there's no sign of it, this is important. You palpate the long bones. So don't forget, when we are the neck, we palpated for the clavicles. So the femur, you get the long bones, you palpate. You check the hands and the feet. Is there any form of simian crease, club foot? Rule out a whole lot of abnormalities. Then there's a special test we need to do. I call them the twin special test. It's the Barlow and Ortolani. Now, what's this test specific for? For developmental dysplasia of the hip. So, watch me, let's do this together. So, for you to see properly, I'm going to be using this region. My baby is going to be lying down. For you to see properly, that's why I'm raising the baby up. So, when it comes to Barlow, you are literally adducting. So, the first thing you do is you stabilize the opposite, the bilateral, whatever. So I'm doing a test on this, or you can even do both at the same time. So you see, for Barlow, what am I doing? I'm coming inside. So I'm adducting. You understand? In a situation whereby it's positive, you know what you will notice? The femur will be displaced. You understand? Say above the acetabulum. So you will literally palpate that dislocation. But in Ortolani case, it's as if you are literally relocating the dislocation that occurred. So what that one do? We do what? We abduct. So when we are abducting, guess what happens? The femur, it will literally be entering back. You understand? So it's the acetabulum. And what will happen? You hear that clunk sound. Clunk. So that's different between Barlow and Ortolani. Now let's move to the next thing. And now we turn the baby prone. So you can see the baby is in a prone situation right now. And what am I checking for? The spine and the back. So I check for signs of spinal bifida. Are you seeing any air tuft? Sinus, dimples. I have to check for this. Sac. Checking for scoliosis. Any masses. We're checking the sacral area. This is very important. The gluteal folds. Then we go to the next state, which is a neurological examination. So let's start with the Moro reflex. So watch. People do the Moro or the stator reflex in different ways. Some will pick the baby's hand and gradually just drop the baby on the second, and I see reaction. You will start to Then the palmar, you put the hand, the palmar grabs you. You put your one of the fingers and put it in the baby's palm, and the baby will grab the plantar grabs reflex, the one we check for Babinski. Okay, let me shift my baby this way so we can see. So what do? The lateral area here. So from this end to the toes, from the sole to the toes, you just, you can use a blunt, anything blunt, or your fingers up your hand, and you just do this. How will you notice? Funny on the toes. The Babinski reflex. Yes. Okay. Then you check for rooting and sucking. I already talked about it. When we're at the mouth level, you remember we did rooting and sucking. Then another one that's very important is the tonic neck reflex. Okay. Now, what do we check on the tonic neck reflex? It's also called the fencer's position. So the baby is sleeping, then you turn the baby to one side. Now, what do you observe? You see the side you are turning the baby to, that side, the hand and the leg, the upper limb and lower limb, they'll be extended. But you see the opposite hand, the one that is on the other side, that area, the upper limb and lower limb, they'll be what? Flexed opposite. You get? Good. So the presence and symmetry of primitive reflexes, they have key indicators of neurological integrity. Now, when we are done with that, you move to the next thing. And what is the next thing? All these must be documented, and you must also counsel the mother. You summarize your findings to the parents. You discuss feeding, sleep patterns, developmental milestones. Yes, and you address the caregiver concerns. You give the patient room to ask questions. Then as a student, as a medical student, what do you do after this? You thank them and you wait on your examiner for any more vital questions. That's it. I hope I've been able to help you. I've been able to, what's that word? Is it confuse you and not? You get it. Don't worry, you get it. Alright. Happy to do this with you guys today. Thank you for watching. Please don't forget to like, to subscribe, to follow. Please share this video. Dr. B wants more subscribers. I want to help more people. Please. Okay, see you next episode. Bye. So the Babinski reflex, the tonic neck reflex. Okay.